Hello, friends. So this is another journal which I'll be talking about in 2021, the key articles that are of relevance to our intensive care. So this is in the specialty of endocrine. This also came in JAMA in December 2021. So metabolic syndrome and acute respiratory distress syndrome in hospitalized patients with COVID. So I'm sure many of the listeners would know the recent COVID trials, especially the remdesivir trial or molnupiravir trial. If you see, these drugs are targeting to the high risk patients who tend to progress to severe stage of COVID. And one of the high risk is obesity. So we need to see whether there is a strong evidence to suggest that obesity are at a higher risk of death in COVID. Although back of mind, all of us know that obese patients did not do well in COVID. So this was one comprehensive study which has really captured a big group of patients to see whether obesity did have bad outcomes. So this is a very important study, especially in the light of us facing the third wave in the pandemic, to see whether obesity has a bearing in such conditions. So this was a study which basically looked into patients who have metabolic syndrome and whether COVID-19 increases the risk of them developing ARDS and increase in the deaths. And it was a multi-centric cohort study from a large database that they took from Society of Critical Care Medicine USA. And the database name was Discovery Viral Respiratory Illness University Study, sort of a database. So they took all the data and they analyzed whether obese patients had bad outcomes compared to non-obese. It's not obese, they defined it as metabolic syndrome. So this study was done in 181 hospitals in 26 countries. So the database came from a large set of country base, which is 26 countries. And this study was done between February 2020 to 18th February 2021. So exactly about a year's duration, they took all the patients from these 181 hospitals. So the metabolic syndrome, how did they define? They defined metabolic syndrome by taking more than 3 criteria. So someone who is pre-diabetes or diabetes constitutes one criteria, someone who is obese, and someone who is hypertensive or dyslipidemia. Any of the 3 criteria amongst these 3 will constitute someone having metabolic syndrome. So that's the criteria they took. So the primary outcome was to look at the hospital mortality. Secondary outcome was to look at patients who developed ARDS, ICU admission, or someone who needed intubation and mechanical ventilation and length of stay. So these were the secondary outcomes they looked at. So this, as you see, the data set was a huge data set, 46,441 patients. 506 patients had metabolic syndrome. So 17.5% of them had metabolic syndrome and 82.5% were control group. So this was the final number they stratified and analyzed. And if you see the risk of ICU admission, the adjusted AOR is adjusted odds ratio was 1.32 in metabolic syndrome. And if you look at this confidence interval, that was statistically significant. It means the risk of ICU admission was significantly more in metabolic syndrome. And risk of intubation and mechanical ventilation, adjusted odds ratio was 1.45. Confidence interval is statistically significant. So again, the risk of intubation, mechanical ventilation was more in patients with metabolic syndrome. And someone who developed ARDS also was statistically significant in metabolic syndrome. And mortality also, as you see, adjusted odds ratio was 1.19 and confidence interval was significant. So all these variables, ICU admission, intubation, mechanical, ARDS, mortality, all these were significantly more in patients with metabolic syndrome, which is obesity, diabetes, hypertension, or hypercholesterolemia. Any 3 of these constituted them to be at a higher risk of these end results. And they looked at the hospital length of stay. And as you see, the hospital length of stay also was longer in metabolic syndrome. It was 8 days as compared to 6.8 days in the control group. And that was also statistically significant. And they looked at ICU length of stay. ICU length of stay also was longer in patients with metabolic syndrome as compared to the control group. So all in all, very comprehensively, very positive signal that is coming out from this, that someone who has metabolic syndrome does have or do have a higher risk of them having bad outcomes, especially in COVID. And possibly in other conditions, we need to look whether this has a similar bearing. And what they interestingly showed, what with each additional metabolic syndrome criteria, which means to say, even if they do not have 3, if there is more than 1, that itself puts them at a higher risk. That was a subgroup analysis they're doing. And if you see, if they have 1 criteria, the risk of them developing ARDS is not significant. But once it goes to 2 criteria, then 15.3% of the patients tend to develop ARDS, and that was significant. That became significant after 2 criteria. And this sequentially increases with every add-on criteria. So once it goes to 3 criteria, 19.3% of them are at a risk of ARDS, and it becomes more statistically significant. And if it is four criteria, 24.3% of them are at a risk of developing ARDS. So there is a sequential increase with every criteria that gets added on, and the proportional increase in the risk of them developing ARDS also tends to increase in a sequential way. So this is a very important message. So one has to look into the metabolic syndrome aspect and try to reform their lifestyle if the outcomes from COVID also has to get better. So because any diabetes, hypertension, hypercholesterolemia, all these have to be kept at in good control so that there is no additional increase in the risk of them developing ARDS. So that was a very strong signals that came from this study. And this is a graphical representation between the control group. As you see, the death was more in metabolic syndrome as compared to this control group. And the risk of intubation and mechanical ventilation was more. And risk of NIV and HFNO also was more in metabolic syndrome. And the need for oxygen also was more when someone had a metabolic syndrome. So, and when they looked at the absolute mortality rate difference, there was 4% absolute mortality rate difference between the metabolic syndrome and the non-metabolic syndrome. And the authors do suggest the metabolic syndrome tend to have a chronic low-grade inflammatory conditions on the background, which predisposes them to ARDS and the following mortality thereon. And this is a very interesting thing for intensivists. So many of the intensive care listeners would know there is something called obesity paradox. What obesity paradox the earlier studies have shown is someone who has an increased BMI, who is obese, there is increased susceptibility to severe illness. But the paradox is when you compare this group to the non-obese, obese patients have better outcome. That is the obesity paradox, which means they have improved survival. So when we take these patients with severe illness and compared to someone who is not obese, although the severity of disease is more, but the non-obese don't do well. Obese have a better survival. This is the obesity paradox. Now the whole question remains, this paradox may not be applicable to COVID, because in COVID we are seeing the opposite, because they are obese, but there is no improved survival. There is a worse outcome. So it beats the obesity paradox. So the COVID does not subscribe to this obesity paradox, whereas the earlier studies which came in ARDS showed that obese patients tend to do well as compared to non-obese, although the severity may be more. So that is the high point of this study. So the limitations of this study was there are a lot of unmeasured confounders, like because this was done in around 26 to 28 countries, whether hospital access was the same, whether the hospital care pathways or the system factors would have been very heterogeneous amongst these countries and amongst these hospitals, and that has not been factored in. And various socioeconomic strata of these different countries and different hospitals also is not factored in. So these are all biases that may have acted as a confounders. And the deaths could have been due to concurrent other bacterial infections, which is not captured in this study. And whether in all these countries, in all these centers, whether adherence to good ARDS ventilation with protective lung ventilation was practiced, that is also not mentioned or captured. And there are selection bias and information bias, as this is a database-based sort of a study, and it's a retrospective study. So these are all the potential biases that tends to exist in any of such studies. So these are some of the limitations of this study. So all in all, the conclusions: someone with a metabolic syndrome, which they defined as 3 of these 4 criteria, pre-diabetes, obesity, hypertension, or dyslipidemia, did have higher risk of mortality, and they stand a much higher risk of developing ARDS. And this ARDS, the risk of ARDS increases with each additional metabolic syndrome criteria that gets added on in a sequential way. So that is the take-home message. So we knew this in back of mind, we sort of knew, but this is the hard data, which shows very clearly with a very strong signal saying obese patients do stand much higher risk of developing ARDS and subsequent mortality, and increase in ICU length of stay, increase in hospital length of stay as well. So that's the message of this study. So thank you one and all.